This is Urban Health Today. I'm Tamara Thomas, editor-in-chief of Urban Health Today, and I'm speaking with Dr. Julie Schulz, physician executive and product leader, as well as VP of product at Avalon Healthcare Solutions, and Michael Dovidio, PharmD, product manager at Avalon Healthcare Solutions. And we're here to discuss determining coverage for GLP-1 drugs in diabetic and obese patients. Thank you both for being here today.
Thank you. Happy to be here.
Thank you. Yeah, thanks for
Awesome.
having
Well,
us.
it's a pleasure to have you. All right, let's get started. Please talk about your respective backgrounds and your work with Avalon Healthcare Solutions.
Absolutely. So I'm Julie Schulz. I'm a VP of product at Avalon, overseeing our analytics and quality improvement efforts. I'm a physician by education. Although I went straight to the dark side, I didn't practice, but I've been in healthcare analytics and in healthcare product development throughout my career, and focus particularly on how we can better, as providers, translate evidence into practice in a way that improves the quality of care for patients and reduces health inequities.
And my name is Mike Dovidio. I'm a pharmacist by trade, but I'm a product manager with Avalon. I really lead up our specialty pharmacy side of management. So I was brought in to try and use the company's assets to try and manage costs in the specialty pharmacy space. But as well as that, I work on with Julie and some of our other product managers on our using lab values to impact care changes in oncology or cardiometabolic health or a variety of other health areas. I've worked in a bunch of different roles as a pharmacist, starting from your sort of standard dispensing, going all the way up to managing pharmacies, launching tech-enabled pharmacies. And so, with Avalon, I come with experience not just in the setting of the retail pharmacy, but also with a bit of technology and automation background.
Can you explain how lab values, specifically A1C levels, are currently used in determining coverage for GLP-1 drugs in diabetic and obese patients?
Absolutely. First of all, an A1C, a hemoglobin A1C, is a lab value that helps to measure a patient's whether or not a patient has diabetes, whether they're pre-diabetic, whether they've had uncontrolled blood sugars. And GLP-1s are a great drug for diabetics, have been shown to significantly improve outcomes. Now, what we're seeing today, though, is as folks started to realize that these drugs are effective not just for treating diabetes, but also have significant impact on weight loss. There were more and more patients looking to get access to them. And in some cases, trying to get them covered by their insurance companies by saying that they have diabetes, or perhaps trying to get that through insurance without any checks or balances on what their A1C values, how uncontrolled or controlled their diabetes is. Unfortunately, what we saw initially is that a lot of, first of all, health insurance companies started to put in some of those checks and balances. Perhaps it's a prior authorization, perhaps requiring some chart notes from the physicians. But what's interesting, because a lot of these health insurance companies don't necessarily have access to the lab values, such as an A1C, to really check to see whether the patient's diabetes is under control or out of control. A lot of times they relied on what a physician reported, whether that was just a reported diagnosis, or perhaps there were no checks at all. Then the patient just kind of was able to get the drugs without any additional review. What we're seeing as the costs in GLP-1 drugs have started to skyrocket, I think rightly so, insurance companies are being more and more careful about who is getting the drugs and making sure that patients qualify for them. I have not yet spoken to any health plans who have today put requirements for an A1C in place, and beyond any sort of physician attestation. But I think that's the direction that many people want to head. The problem is it's very hard to get access to that data. And you also want to make sure you're still making sure patients who do need the drugs don't have to jump through additional hoops. So I think there's a lot we can do with making sure that insurance companies and providers are using that data, not just to ensure that the right patients are getting coverage, but even to help to target which patients are going to need the drugs the most and which patients are going to be most likely to benefit.
with about 20 to 30% of these claims coming from patients with uncontrolled diabetes, without uncontrolled diabetes, what challenges does this present in terms of health equity for marginalized patients?
Yeah, I mean, we always think about obviously costs, right?
Mm-hmm.
There's really in my opinion, a two-prong issue here with trying to ensure that that the GLP-1s get to the most unhealthy patients. So first of all, it's the cost, right? And as Julie talked about, using lab values like A1Cs can help properly allocate the dollars spent on the patients who are most unhealthy. There's also a supply chain aspect at play here too, because the challenge from a patient's perspective doesn't stop once they get the prescription written. They then have to go to the pharmacy and find the drug. And I can tell you, being on that side, it's not always easy for a pharmacy to stock these meds and have enough in stock to be able to dispense them to all the patients that want them. I remember at the previous pharmacy that I managed, I think we signed on to 4 different suppliers every single morning and just blanket ordered whatever they had in stock to make sure that we had it. So, I think that, like I was saying, there's really 2 aspects to consider here. It's, how can we start to use more objective measurements? And by the way, like, what most plans are using today in their policies from an objective standpoint, is a BMI, a body mass index, which is not always, in my opinion, the best marker to use. It doesn't really paint the full picture.
Right.
I think as Julie and myself and others at Avalon have really started to think about this, we've started to use the term cardiometabolic healthy or cardiometabolically unhealthy, as opposed to just somebody who's considered obese. From a personal standpoint, my BMI is above 30. I qualify for a GLP-1, but I wouldn't consider myself to be cardiometabolically unhealthy. And so therefore, I'm kind of the case of the person who can get the drug and could get it covered by my insurance by definition of the policy, but shouldn't necessarily.
So how can leveraging lab values improve reallocation of the GLP-1s to underserved communities?
So I think especially what Mike's referring to is when GLP-1 drugs are indicated both for diabetes as well as for obesity. And most insurers cover it for diabetes today. Where things get a little bit dicier is whether or not insurers want to provide it for obesity. When we look at commercial plans, about half are covering it today, but it's really been a struggle because of the cost. A lot of health plans have really struggled with their pharmacy budgets, and so that's what brings us to this question of BMI. We've recognized that obesity is a disease, and it's an illness that needs to be treated. However, BMI today is the only biometric that we really have to define obesity, with a BMI of 25 or over being overweight, and a BMI of 30 or over being obese. Now, as Mike just mentioned, that facilitates, unfortunately, a lot of underdiagnosis of obesity. There's a lot of patients who could have a quote unquote healthy BMI, but have genetic or other lifestyle factors that put them at high risk of downstream cardiometabolic disease. And there's also patients, especially folks who are particularly fit, have a lot of muscle mass that might actually meet that BMI criteria of being obese, but those patients may not actually be at risk for some of those downstream sequelae of cardiometabolic disease. So I think it really brings up the question, what can we be using instead of BMI? And this is where lab values really come in. When we look at what cardiometabolic disease is, so that's uncontrolled glucose measured by a hemoglobin A1C, it's having high lipids measured by your cholesterol, but also it involves kidney disease, looking at your estimated glomerular filtration rate as a part of this picture too. And so what we've seen is that the American Heart Association has really migrated toward this more holistic picture of cardiometabolic disease to really incorporate all of the different comorbidities that are part of cardiometabolic syndrome. And they've actually started to use those lab values now to predict downstream adverse cardiac events and heart failure. And so that's really what we are starting to work with our health plan clients on, is how can we better use those lab values, and specifically some of the equations that have been created by the American Heart Association to better perhaps select patients for GLP-1s, and also to potentially use as coverage criteria for GLP-1s, so that we, again, direct the medications to the patients who are most likely to benefit.
I was just going to say, I think that also, using lab values or leveraging lab values, that helps with the financial aspect of making sure that we're directing dollars to the patients who are going to benefit the most from it. But I think when we talk about underserved communities, you also have to consider that an underserved patient may have transportation issues, right? And when we go and sort of put the lens of supply chain issues on, it's like, well, this patient's having a hard time getting to the doctor or one pharmacy, and that pharmacy's out of stock on that drug. They're not likely to go travel around and try to find which pharmacy in their area has the GLP-1 that they're looking for in stock. So I think if we can start to use more lab values to paint the picture of cardiometabolic health above and beyond just BMI markers, we can really start to impact not just the dollars, but also the supply chain and the procurement of the drug, to make sure, like I said, that the patients who need it the most, who, by the way, are also usually the patients who cost the most, can have easy access to the drugs on the.
So you're not saying that obesity shouldn't be a factor, because obesity is a factor in many diseases, as you pointed out. They're a factor in heart disease. They're a factor for diabetes. They're a factor for kidney disease. So you're not saying that. You're saying strictly BMI and the way BMI is being interpreted.
Yeah, I think that's right. I think there's general consensus in the medical community that BMI is just not, it's an imperfect biometric, if you will. And so there is, I think, more and more focus on trying to find other criteria. So, for example, a lot of insurance companies might require patients with a lower BMI to also have other comorbid illnesses. So that's one example of how you can direct toward patients who have a higher cardiometabolic disease burden. But also what we see is that some of these patients who, for example, in chronic kidney disease, these patients are very sick. Oftentimes they have multiple comorbidities. They cost health insurance companies thousands and thousands of dollars a year. And one of the biggest factors one of the biggest things that can help both reduce or prolong, I should say, actually delay progression of chronic kidney disease, but also keep patients out of the hospital, is keeping their A1C controlled. So it makes sense clinically and from a financial perspective that you'd want GLP-1 drugs that are very effective at reducing hemoglobin A1C to go to these patients, like chronic kidney disease patients, who are going to most benefit. And actually, you may even see some of that cost effectiveness play out, again, because then you're keeping these patients out of the hospital.
It's funny because physicians used to counsel obese patients on weight loss, like, change your diet, change your lifestyle. I wonder why physicians have moved away from that for obesity and have gone straight to the drug. Is it because you think, and I'm asking you this, as clinicians, a lot of underserved people, for example, that eat diets that are not, they live in food deserts, let's say, for example. So the food that they're exposed to on a regular basis, the food that they can afford to eat, is not the most wholesome food. Do you think that there's a change in how obesity looks today? Or and
so
from that, we on to
yeah.
the GLP-1, say, for example.
So a couple things. And first, I want to make it very clear from a clinical perspective, GLP-1s do not replace counseling, diet, and exercise. It's just one other tool that should be used in combination with those things. But I think on the flip side, let's be honest, a lot of the counseling that providers have given to patients historically for obesity could sometimes could actually turn patients away from the healthcare system. And frankly, we haven't really had effective tools in our toolbox to treat obesity, and that's really alienated a lot of patients and communities from accessing the healthcare system and going to their physician or their provider for help with obesity. So I think that in many ways, GLP-1s are a good thing because we're already seeing a lot more patients accessing healthcare and going to their physicians to get both the medications as well as that counseling and diet and exercise. But I don't know, Mike, I'd love to hear your thoughts kind of on a lot of these consumer facing companies that have popped up as a result of this, because frankly, a lot of, like I said, patients historically haven't really gone to their primary care physician because they felt alienated or because they may not have had access.
Yeah, so I think first, to answer your question directly, Tamara, in my opinion, it's, GLP-1s have become easier to prescribe than going through obesity counseling, right? And let's be clear though, treatment guidelines for diabetes, for high cholesterol, for hypertension, it still starts with lifestyle changes. So nothing's really changed from the treatment guideline aspect. It's just we've had this new sort of easy button introduced. I think Julie has made a great point, though, that that has actually empowered patients to become more involved with their own healthcare, which is phenomenal. I love that. But I think there's multiple things at play here when we talk about this. It's not just the dollars; it's also the time. Patients who are they willing to commit to the lifestyle changes necessary to decrease their weight, right? Because treating obesity is hard, right? When you're not using drugs, you're talking about habit changes, and there's a lot of fundamental things at play there, right? If you are living in a food desert where you only have access to food that's not particularly healthy, your chances of committing to lifestyle changes that are going to help you get on a path of lower obesity, probably goes down tremendously. On top of that, there's the time, and I want to be clear, your time for physicians to counsel, which has gotten strained because there are more patients in the healthcare system, and providers just don't have as much time as they used to sit and talk with patients, but also time on the patient side too, right? If you're working two different jobs to make ends meet, you're not likely to go home and cook a robust meal of whole foods with lots of vegetables and stuff. It's easier to just go to McDonald's and go through the drive-through. So anyway, I think to your question, like it's really become this sort of easy button for providers to turn to. But on the flip side of that, it has also increased patients who want to take their own health into their own hands. And I think Julie had raised the provider-facing companies. We've seen a increase of, I'll call them like digital or online pharmacies, predominantly in the compounding space, who have really taken, with tirzepatide in particular, Mounjaro being on the the FDA shortage list, it has allowed for the introduction of these compounding pharmacies that are more consumer-facing to come out with apps that make it, quite frankly, really, really easy to get a hold of these drugs. I'm not talking the brand drugs. They can get the compounded drugs from basically their cell phones.
From their cell phones? Really?
Yeah, a lot of them have apps now. And it's funny because when you log in and have a chat with the provider, the first thing they typically ask you is your height and weight, which are the two pieces that go into the BMI calculator.
Which brings you back to square one.
And your credit card number.
Yeah. Yes.
Well, let me ask you, in what ways does overprescription of GLP-1 drugs affect women's health, especially women who don't necessarily meet the clinical criteria, but are influenced by, let's say, societal pressure to be thin?
Gosh, I think there's a few things to say about that. So first, going back to BMI as an imperfect biometric, women in particular are going to be more likely to be underdiagnosed with cardiometabolic syndrome because they don't have as much muscle mass. And so I think, again, going back to lab values and going back to finding other metrics of cardiometabolic health, are really important in assessing a woman's overall risk. We know that historically, that both society and the healthcare system have thought of heart attacks as a men's disease, and that's not the case, right?
Right.
And so, first of all, I think starting to think more holistically about cardiometabolic health beyond BMI is only going to help more women meet the criteria and get access to the drugs who need it. Now, I think that answers sort of the clinical side. I think that would be a great thing, for women's health. On the flip side, then there's this consumer piece, and GLP-1s are just one more cosmetic. I don't want to say tool, but one more thing that women are chasing after, again, to perhaps to achieve unrealistic norms of what their body should look like. It's tough because I think on one hand, we really want to make sure that these very effective drugs are going to patients who need them. But we also have to be really thoughtful about not overprescribing to patients who don't and not creating those shortages. Now, I think uh, like Mike mentioned, my hope is that most responsible providers are really reserving the drugs for the patients who are the sickest, especially the drugs that are coming from the pharmaceutical companies, and then really leaving kind of the compounded drugs for some of those more direct to consumer spaces. We can't stop that from happening, but my hope is that the patients who are pursuing the drugs for more cosmetic reasons aren't really taking the higher quality brand name drugs away from patients who need them.
Well, how would better use of lab data support physicians in making more informed decisions in prescribing? Because it doesn't seem like that's what's in place right now.
We have to really, first of all, we know physicians are they've got a lot on their
And this
plate,
is not
right?
a
They're
knock on physicians. I'm not
And
saying
no,
right.
and I think, but it's also important to recognize the challenges that they have, the burnout that they've experienced, and so we really need to think about the entire journey of how a patient, accesses these drugs, how we can support physicians, provide them that information at the point of care. So that they can better select the right patients. We're working on projects right now where we do exactly that. We look through a health plan's data and the lab values of their members and identify which patients are most likely to benefit from GLP-1s. And we provide that information to the providers on the front end so that when the patient comes into their office, they're already a step ahead in deciding who should get the drugs. But then the next step is on the prior authorization side, when the insurance company decides how to cover the drugs, then they are going to be looking at this lab data and this lab information just as a check on the physician to make sure that the patient is really meeting those criteria. And we can do that very seamlessly by providing that data not just to the physician, but then also to the health plan as well. Because again, we want to have the right barriers in place to access, but we don't want to create so many barriers that the patients who need the drugs aren't getting them. And then on the back end, we need to continue to evaluate outcomes for these patients. We're still just learning what the impact is and how these drugs impact obesity in the real world, but also how they affect downstream cardiometabolic outcomes. And we can use that data to better hone our targeting and better look and take a closer look at our problems and address things like health inequities so that we can continue to improve in not just the distribution of these drugs, but also in achieving better cardiometabolic outcomes for our patients.
So how does Avalon Healthcare Solutions propose to implement lab value verification without adding additional barriers for patients who genuinely need the medications?
Well, that's exactly it. So because we have access to the lab values ourselves, then we're basically reducing the administrative burden on both the physicians and potentially on the patients as well by basically automating the process by which we select patients and by which we approve insurance coverage for the drug.
Yeah, I mean, so we were talking about it earlier. Health plans a lot of times don't have access to these lab values, right? So if a plan wanted to implement something like an A1C as part of their coverage criteria, as it stands today, the only real way to do that is to have a prior authorization, which means you have a person sitting there reviewing the charts, which costs time and money and leads to both provider and patient frustration. So if you think about it, a sort of future state world where the lab values flow directly from the lab to the insurance company, you can essentially now use tools and technology to automate some of that piece where you're not actually requiring a prior auth, you're just automating it through technology at that point. So there's you can still have that check and balance in place from a health plan perspective, but you're not relying on a human to sit there and review the notes. You're not relying on a practice manager to fax the notes into the health plan. Nobody really likes prior auth. I don't know. I don't feel like health plans don't even like prior auth sometimes. So, but it's one of the only tools in the toolbox from a health plan perspective. Again, because the access to lab values or that objective data that can be used is so limited right now. And we feel like from our standpoint, we can start to bring some of that, and introduce it, which will in effect decrease the prior auths.
I would worry, and you can speak to this, but I would worry personally about a payer having my lab information because I would worry that they would take that information and it could affect future premiums or whether they even give me insurance in the future. What do you say to that?
You want to take this, Mike, or?
Yeah, I mean, so I think the question you're really after is, can lab values can we start to use lab values in a way that decrease premiums, right, and doesn't leave more patients stranded? I think first of all,
I guess what I'm asking more specifically is, would in the case of providing labs to the payer or to the insurance company, I would hope that the only information they're getting is the information that's completely relevant to the prescription approval process and not any additional. Because when you do the labs, it's a bunch of things. They draw the blood and they do a bunch of things, including the A1C, including other stuff.
Mm-hmm.
So do you make that other information blind or redacted so that the insurance company doesn't have that?
Yeah,
So
right. So it would be. Oh, sorry, Julie. I was just going to say, so I mean, it would only surface the relevant information for that clinical case, right? And we would do that sort of conditionally on the diagnosis or the drug that the doctor is prescribing, right? So from a technical standpoint, as the claim would come in through the sort of claim process for that drug or for that condition or whatever, there would be essentially rules set up to say like, it's this type of drug, it's a GLP-1, we need an A1C, right? And so it would not show really any of the other lab data, just what's completely relevant for that clinical condition.
And I want to make sure it's important to say that there are laws preventing insurance companies, especially related to genetic data, from using that information for adverse coverage decisions. However, I understand. I mean, I think I can tell you when I was pregnant, I was older, and someone from my health insurance company reached out to me and said, "Hey, are you interested in these services in these additional support for your pregnancy?" And that's a really awkward phone call to have because, frankly, I don't think most patients really trust their health plans. They're much more likely to trust their providers. Now, on the flip side of that, I don't think we really need to be working, as a team across providers, payers, community health workers, to address this problem. If we don't work together, then we're not going to have that data. Often health plans have those resources to open up access, and ultimately are the ones, setting some of these coverage determinations. And so I really think that health plans are in a very unique position, not just to start capturing some of this lab value data, but to increasingly also get real and SOGI data. So that's ethnicity, and language data, as well as sexual orientation and gender identity. And we are seeing the NCQA now starting to actually include the health plan collection of that data into star ratings. Some health plans have already gotten ahead of the curve and have that data, because again, if we don't have that data, we can't address those health inequities. So collecting it is very, very important. But of course, a lot of health plans have struggled to collect that data because a lot of folks feel uncomfortable providing it. And so that's where those partnerships with the providers that patients are more likely to trust, the community-based organizations that patients are more likely to trust. We all have to work together to make sure that patients understand how that data is going to get used, and really, hold ourselves accountable to use that data to improve access and to improve the quality of care.
So if lab values are more effectively used to determine coverage for GLP-1s, do you believe it'll impact healthcare costs and insurance premiums?
Oh gosh, I think I'm going to take a step back on that, because I think GLP-1s are just one part of what is increasing costs in healthcare and what's increasing insurance premiums. Um, I, Mike, I know you've kind of taken a closer look at some of the trends in pharmaceutical costs. Do you want to talk a little bit about kind of what's happening with that, how it's impacting health plans?
Yeah, so look, costs are increasing across the board for plans, but I
Yeah.
think specifically when we think about GLP-1s, it's really come down to this the situation where there's just simply not enough money for a health plan to cover GLP-1s for patients where it's indicated, let alone patients who want it, who it may not be indicated for. For example, there was I think Blue Cross Blue Shield of Michigan, their pharmacy spend. There was a report that came out earlier this year that their pharmacy spend increased by it was like around $2 billion,
Oh, wow.
and around 400 million of that was GLP-1s alone. The other half of that was specialty pharmacy drugs, but that alone led that health plan to layoffs. And so I think there's a very real question here of where does that line in the sand get drawn, right? And like, let's be clear, it's I think it would be unrealistic to say that using lab values will help decrease costs in GLP-1s, right? It may help bend the cost curve, or as I said earlier, properly distribute the dollars to the patients that sort of need it most. But GLP-1s, we're at the tip of the iceberg right now. I mean, Byetta was the first drug approved in 2005. I think we're up to around 10 when you include the drugs that have weight loss indications. And there's around 130 that are in the pipeline today. And that's just new drugs coming to market. There's also new indications coming out for GLP-1s. So I think we're going to continue to see not just the number of GLP-1s expand. We've got single drug agents. We've got tirzepatide has two different molecules inside of it. There's 3 molecule drugs coming down the pipeline. So it's going to become increasingly more important to make sure, in an effort to not increase premiums to the point where it's effectively totally inexpensive for anybody. Nobody can afford it anymore. It's going to become increasingly more important to really try and use other means to, like I was saying, make sure that the dollars get allocated appropriately.
So you don't believe that it'll necessarily impact healthcare costs and premiums, but by way of redistribution, it'll sort of settle it out and not make the price go up. So it won't go down, but it won't go up if it's properly allocated. Is that what you're?
So Well, so here's what I was trying to say. Like, I'm going to talk in terms of specialty pharmacy because I'm a bit more familiar with that.
Okay.
Specialty pharmacy drug costs for the last 3 years, I think, have grown at 14% year over year. I mean, there's been reports coming out that the specialty drug class of the class of specialty drugs has increased between 10 to 15% year over year. And so when I think about using lab values, it's not so much to decrease the costs overall. It's about, can we get that 10 to 15% increase year over year down to something that's more in line with, like, our previous sort of inflation rates in this country, but something more reasonable that's not such a dramatic increase year over year.
Mm. Can you share examples or case studies where improved use of lab data has led to better patient outcomes and equitable distribution?
Yeah, sure. So, as I said at the top of the hour, one of the other sort of projects that we're working on is using lab values to impact oncology care. So, classically, in the realm of oncology, when you were diagnosed with cancer, the first sort of questions that would come to mind is, where is the tumor and what type is it? Is it a solid tumor or a liquid tumor? Nowadays, there are genetic tests that will test the sort of genomic profile of that tumor. And instead of using a chemo agent to treat that drug, there are guideline concordant genetic targeted oncology agents that can be used to treat those tumors. And so, what we're trying to do there is basically a lot of what we've been talking about today is can we identify patients where the genetic test is indicated, and can we auto approve the PA for that? And then, based on the results of the genetic test, the genomic profiling of that tumor, can we match that through guidelines to the guideline indicated drug, and again, approve the PA for that drug? And in that case, we've seen some real data where, there's a percentage of patients where they are on a targeted therapy without having the genetic test done in the first place. And on the flip side of that, there's a percentage of patients where they get the genetic test, but they're not on the guideline indicated drug. And what that leads to is higher costs, longer timelines, which means, in the world of oncology, which is, basically less years for that patient. And so some of the data that we've been looking at is, by way of auto approving both the genetic test and the drug for oncology, can we speed up the time to getting to those guideline indicated drugs? And will that decrease costs overall? And will that increase years of life for that patient? And we have some anecdotal data from some studies that are out there, that it can range from saving like $600 a year per patient to well over like $100 or $1,200 per patient. And that all starts to add up. And that, again, allows you as a payer to sort of start to reallocate those dollars to where, to be most impactful for your patient population.
And I think on the cardiometabolic side, rather than looking at a single test and that is related to a single treatment, when we look at the constellation of a patient's cardiometabolic lab values, we know that patients who are more cardiometabolic healthy in the chronic kidney disease population, for example, cost about $5,000 less a year. So if we can then when we take our data and provide that to physicians, our hope is that then they can select the right drugs and focus their efforts, not just in terms of GLP-1s, but other resources as well, other cardiometabolic drugs like SGLT2s. If they take those drugs and those resources, focus them on the patients that are most cardiometabolically unhealthy, they're going to be, it's very possible that they can take that population and reduce their overall cost of care by about $5,000 a year, which could actually turn out to be cost effective. We don't know yet. I think we're still at the phase of projecting what some of the impact could be, but we need to start using this clinical information to direct the resources towards those patients, so that we know not just who's going to benefit the most, but also how we can use the drugs to best bend the cost curve, if you will.
Considering the popularity of GLP-1 drugs for weight loss among celebrities and affluent individuals is not going away anytime soon, I think we sort of all agree on that. How can the healthcare system ensure that low-income patients who meet the medical criteria do not get left behind?
I think I'm going to kind of talk a little bit more about what we mentioned previously. We need to have that data to understand who these patients are, continue to kind of use that in terms of patient selection and resource deployment. And frankly, that's been just having that data and has been a bit of a challenge. I think what we're excited to do is to work with some health plans who do have some of that data to start setting the standard, having kind of case studies of how that outreach and how deployment of those resources to patients who are who need them the most, to see how we can, if that's possible, how effective it is, and what the costs are as a result of it. But I think Mike, anything on the supply chain or the pharmacy side that you
Yeah,
think of in
no.
terms of
So
that?
again, as we've been talking about, there's this sort of two-hit issue here, right? It's the dollars on one hand, but the supply chain on the other. Um, and let's be clear, right? Like just because the insurance doesn't cover the drug, patients can still go buy it at
Right,
cash
exactly.
prices as long as they've got a prescription for it. So, um, I think the thing here to keep in mind is that there are outside of the brand products that are available, like we were saying earlier, there are compounded products that are available that in the case of when the brands are not available, patients can always go to the or the compounded products as I don't want to say substitutes, but alternatives. Um, but I think that you know by using lab values again to sort of better allocate the resources, we can think about it not just from the dollar side, but from the supply chain side. And if the health plans, if providers rather, could really start to harness the lab values in a way that allows your most sick patients who are most in need of the products can align with the insurance coverage in a way that allows that procurement and supply chain process from the pharmacy aspect to fulfill it the correct way. I think that's your sort of three-hit um, you know allowance if you will to your sort of most underserved patients to having most likely access to those drugs.
But how do you get this data into the right hands to even begin this process?
I think, like I said, it's not everyone trusts their health insurance company. Where people have been more successful in collecting the data is when they partner with community-based organizations, faith-based organizations, folks who already have that trust of the community. And we also need to create better standards for how we collect that data. And that's, I think, part of what some of the health equity initiatives that the NCQA has is pursuing, is creating those standards so that what happens in, we can actually extrapolate what happens in one part of the country to what happens in another part of the country by using the same language, the same terminology, the same, groupings of individuals. I think that's the first step. We have to have the data first if we're going to develop programs to better sort of impact these communities. But it's not, I'd be lying if I said I think it's going to improve overnight, or if that lab values is the only answer. It's lab values, interoperability, collecting this data, and then the partnerships that we create across the healthcare ecosystem. Because health plans can't do it by themselves, and nor do I think we totally want to trust them to do it by themselves either.
Julie and I joke about the sort of trifecta of data, right? There's the medical claims data, there's the pharmacy claims data, and then there's the lab claims data. And it's very rare for one single organization to have all three of those pillars at the same time. I mean, let's face it, healthcare is fragmented, right, in a
Right.
variety of ways. But to Julie's point, from a data standpoint, um, you can kind of think about it as three different languages. And you not only need translators to be able to take the lab data and make it match up to the medical claim or the pharmacy claim data, you also need access to it. Medical claim data traditionally lives with your health plan. Pharmacy claims data traditionally lives with your PBMs. Lab claim data traditionally lives with your labs. And so it's not just pulling all of those together, but it's making them match in a logical way from a technical standpoint, um, so that the same patient, all three of that data stream matches for the single patient. Because a lot of times it's not as easy as what I just described. I mean, it's way more
Well,
challenging.
and then getting it into the hands of people who are actually at the point of care working with patients. If you already know a patient's preferred language, you can make sure you have translator services already, in place before the visit. Small things like that make a really big difference. And so it's not just collecting the data, but then having the mechanisms to share it appropriately, so that it can have the most impact.
I guess I'm trying to understand, forgive me for not quite getting this, but I'm trying to understand how Avalon Healthcare Solutions going to make this actionable.
I think it's exactly what I just said, getting that data into the hands of the providers at the point of care ahead of time, so that before the patient even comes in, they know, they have perhaps an index or a sense of how cardiometabolically healthy or unhealthy a patient is. They know what challenges that patient might be facing in terms of social determinants of health or in terms of their, like I said, preferred language, and can have an actual care plan, if you will, already kind of written out for them. And perhaps a nurse or a care coordinator starts to kind of review that with the patient ahead of time, or perhaps the physician kind of goes through that checklist. There's a few different models that we've seen. Whether that's the providers actually implementing this versus other care management organizations or community health workers kind of helping to fill some of that gap. But I think it's really making sure that we get, first of all, data that historically, unfortunately, a lot of these folks haven't had at their fingertips, collecting the data, but then making it as actionable and usable in clinical decision support tools as possible.
So,
So
and I
go
think
ahead.
there's an important piece. Sorry, Tim, I keep cutting you off.
It's
Sorry.
fine. It's fine.
There's an important aspect just to sort of describing how to pull the lab data or how to gain access to the lab data, because that's a feat in and of itself. I mean, there
Mhm.
are like 17,000 labs in the US,
Okay.
right? So, and a lot of people know LabCorp and Quest as the two biggies, but they don't do everything. So, um, the way that Avalon approaches it is, we developed a sort of network of laboratories, that we can help manage and pull that data together. And when I say that, the data coming through may be in different languages. I mean, one format of data coming from LabCorp or lab number one could be completely different than the format of data coming from lab number 17,000.
Right.
So, you know, first it starts with, to Julie's point, you got to have the pipes built to pull that data in, but then you have to have the teams to be able to match it all up in a way that makes logical sense. And then you need to have the relationships with the providers, the health plans, to then take that and pass it through in a meaningful way, to affect care. And whether that means auto approving prior auths or removing some of those barriers from the health plan side, you got to have the relationships and the pipes built to be able to do that. Or clinical decision support for the provider. Again, you have to have integrations on that end to be able to pass some of that information down to the providers. And I'm not like Avalon doesn't have this all figured out, but we are we've got a few of the pieces, right? We've got the lab data coming through. We've got connections to the health plan, so we can at least do that aspect. But we're always trying to work with other companies and partnerships to do things like pass it to the provider, or to pull in pharmacy claims data, or to get social determinants of health data, or all these different aspects. We're trying to bring this all together, like we were saying earlier, in a logical way that really helps detail out the patients better for the health plan or the provider or whoever, to just make meaningful action out of it.
Do you use AI to sort through the data so that when the data is passed through from the provider to the payer, their job is sort of easier and it's kind of like bullseye, like here's the data. Do you do anything like that, or is this done by?
Yeah, I'll be honest. We don't today, although we have folks on our team who have a lot of experience in doing that. I think, frankly, the biggest challenges today are just in getting the data and making sense of it at a fairly basic level. That's kind of goal number one. AI is a fantastic tool, but it needs to be deployed in a way that is clinically appropriate. And in a way that it isn't learning from broken ways of delivering healthcare. And so we want to make sure that, first of all, we're collecting the data first. We are encoding best practices, both in terms of how patients are treated clinically, but also how they're treated as a whole person. And then using that to set the framework and to set the standard, and bring AI in at that juncture. That's where I've seen it to be the most successful. But today we have to kind of get the building blocks in place. And then we hope we can use AI to better predict outcomes, better identify patients in need, and to streamline and automate a lot of processes. But in full transparency, as a company, Avalon isn't there yet today, but we want to be really thoughtful if and when we deploy it.
And I think AI makes sense in certain situations, but it just doesn't for this in particular. I wish it did. That would be way too easy. But I'll give you a very real example.
Okay.
For a routine lab test like A1C, there's something called a CPT code, or we call it a LOINC code, LOINC code. And in most labs, that's very easily passed through to Avalon. Right, we've got the data pipes built. We can see the LOINC code. We can see this A1C was done for this patient with this result. When you start to think about genetic testing, it becomes way more complex, because if you're looking for something like a KRAS mutation, first of all, that's a single gene mutation, which could be part of any number of broad-based genome sequencing tests, right? And so each genetic lab may have a different set of broad-based tests. One may have a 63 gene panel, one may have an 87 gene panel, one may have a 600 gene panel. And each one of those have different codes associated. But to further complicate it, the values may be written in a format that's not in a structured data set, right? So it may just be like a PDF, or the result, the KRAS mutation might just be written in the comments section, where it's not easily passed through. And so you have to work with the lab, right? And this is a lot of what our teams do. You have to work with the lab to say, we appreciate that you're sending us this data. However, in order for us to properly use the KRAS mutation data, that needs to be its own significant or specific data element in the file structure that's being passed to us, because AI might be able to help in situations like that, but really it's just not as simple as data being passed from the lab to a provider.
I think what Mike's saying is that some of the most useful ways to use AI are just not that shiny and exciting. There's a lot we can do at a much more basic level with AI, despite I think what you might hear in the popular press.
Well, I wasn't really thinking in terms of genetic information. I was thinking more along the lines of BMI and A1C. But okay, that's a that's a fair point, and that makes
Got
sense.
in the weeds there. Sorry.
It's okay. It's fine. Final question. In your opinion, what policy changes will it take to make lab value verification a standard practice in drug coverage decisions?
I think I don't know that it's a policy change as much as it's just a data access change. We need to start making sure that we have access to this data and we're sharing this data, and then writing the coverage determinations and policies, leveraging lab value data when that is going to be a much better indicator of a patient's health than a diagnosis code, and it's going to be a much easier way to assess a patient's cardiometabolic health.
So you don't think that policy changes would be necessary to help with redistribution and reallocation? Because I my feeling is, and I'm a layperson here, but my feeling is without some sort of policy change, I don't know that anything is really going to change in terms of the way, even with lab values,
Mhm.
without policy, I just think that doctors will continue to do what what their affluent patients want them to do. If the patient comes in and the patient says, I need to lose 20 pounds for vacation or a wedding that's coming up or a motion picture that I'm working on, they're not going to refuse that, whether the lab values are there or not. So again, I will ask you, what do you
So
think policy changes? What policy changes do you think? I mean, and if you
yeah,
don't think so, that's fine.
no, no.
But I
I,
just
I, I I don't know that it's federal policy changes necessarily, but there's other kinds of policies that can have impact on these things. So the health plan policies. I'm attending next weekend the American Heart Association conference. They create guidelines um, for how we care for our patients that hopefully can start to break away from BMI. But they're really using the evidence to drive that. So maybe I'm skirting the question,
no, no.
but I think those are the types of policies that are going to be policy changes that are going to be most impactful um, uh, to affect physician behavior.
Well, so I think there's different policies that we might be talking about here. So Tamara, can you just, when you think about policy, are you think about a federal policy, a state policy, or you think about a health plan policy?
Well, I'm thinking in terms of policies for insurers across the board. So if there's a governing body for payers that look at this information and say, hey, we can't approve this unless we have these lab values, then I think that would prompt providers to make changes in how they prescribe. Yes, no?
Maybe. I think it would. So, okay, let's back up a second. So there are medical drug policies from the health plan perspective, right? I think
Mhm.
that in order to effectuate lab values being used there does need to be some change in the medical policy. As I think I said this earlier, but as it stands today from a health plan policy perspective, it's mostly only BMI and diagnosis. You have to have a diagnosis of diabetes and or obesity, and your BMI needs to be, I think 35 is what I've seen most in 35 or higher in most health plans. So there would need to be criteria added to that policy to say, well, now you need an A1C and maybe some blood glucose readings, glomerular filtration rate, and some of the other stuff that Julie talked about earlier. So I do think that there would need to be health plan policy changes in order to use lab values. And again, I think that in order to even educate a health plan on what policy changes they need to have, you got to have the relationship with the health plan. right? And so that's, you know, an area where I think that Avalon kind of shines is we've got those relationships. From a sort of state and federal standpoint, that would impact the prescribing of providers there. I don't know that there's much that a federal policy or a state policy could do. You know, at the end of the day, if it's clinically indicated to have that drug or that GLP-1 prescribed, you know, maybe the guidelines could change, but I personally speaking, I don't see where a federal or state policy could have any impact on the prescribing rights of, you know, a physician.
Except perhaps I think for Medicaid coverage, where that does come from the state level. Yeah.
Well, yeah, I mean, but they could still prescribe the drug for the
That's true.
Medicaid patient.
Yeah.
It's just that it may not be
It wouldn't get
covered
paid
by
for.
it.
Yeah.
Right. Right.
Hmm.
But I think there's two different things here, right? There's prescribing it, and I think about the like supply chain procurement side there, and then there's the covering it, which is the cost aspect of it. So you know, a federal policy change may help with the cost side, and I think we're already seeing CMS and HHS do some of this with the new negotiated drug prices.
Right.
There's also, Julie talked about interoperability. I mean, we're seeing you know, CMS make a stance and say by 2027 systems need to be able to talk to each other.
Right.
So there is some of that already coming down the pipeline. But from the what can the doctor prescribe side, I don't know that there's really any policies that can impact that.
Yeah, this really is a complex issue. There's no easy, clean answers there.
Everybody's trying to figure it out right now.
Yeah. All right. Well, Dr. Julie Schulz and Michael Dovidio, thank you so much for your time and your expertise today. I really appreciate talking to you about this very thorny, complex issue.
Thank you. It was a great conversation.
Yeah, thank you for having us on. Appreciate it.